Okay. Welcome everybody to another live stream Q&A with NCAN. I am your host, Mike Wayman, and we have Dr. James Howe here from the University of Iowa. We're going to talk to him in a second. Just real quick, I want to get some light housekeeping out of the way. Next Saturday, on June 21st, we're going to be in Minneapolis, Minnesota. We have an awesome lineup of doctors. We have Dr. Joe Dillon, Dr. Thor Halfdonnerson, Dr. Mary Maluccio, of course, Dr. Howe here. Also in July, we have another one coming up. It's going to be in Birmingham, Alabama. This is going to be our makeup of the March edition that we were supposed to do that unfortunately was shut down due to some hurricanes, but we're back, and we've got Dr. J. Bart Rose, Mary Maluccio again, and a whole bunch more. We also have events in New Jersey this fall, Miami this December. If you want any more information on those events, please go over to netcancerawareness.org in the events page, and you can keep up to date with all that. But as I mentioned earlier, we have Dr. James Howe. How are you, sir?
I'm doing good.
We are really excited to have you here. Dr. Howe is a professor of surgery at the University of Iowa. He is a longtime friend of NCAN. But real quick, let's just tell us a little bit about yourself, how you got into NETs, and a little bit of your backstory.
All right. Well, I'm a surgical oncologist. That means I do cancer operations. And I grew up in Vermont, went to Vermont Med School, and then I did my residency in St. Louis, did a fellowship at Memorial Sloan Kettering in cancer surgery, and then moved out to the University of Iowa 1996. And in 1999, two wonderful people, Tom and Sue O'Dorisio, came to the University of Iowa. And Tom approached me and said, "Do you want to be my neuroendocrine surgeon?" And I said, okay, sounds good. And I didn't know a lot about neuroendocrine tumors. I mean, I knew something about them, but Tom really immersed me in the world of neuroendocrine tumors because he and his wife Sue had been taking care of people for a long time, and really got me really excited because both of those individuals are just such wonderful people, warm and generous. And Tom, bless his heart, has been, a great mentor and enthusiastic guy who really got me into taking care of neuroendocrine tumors. He sent me a lot of patients. And, over the decades, I've learned how to take care of them in a multidisciplinary fashion with Tom and Sue, and now Joe Dillon and Chandrika Chandrasekaran, and Thor used to work with us. So we've had just an awesome group for a long, long time. At Iowa, the Odorisios brought the first gallium scanning to the United States, and we were also doing the first PRRT back in 2001 in clinical trials. So we've got a long history of doing stuff at the University of Iowa with neuroendocrine tumors, and I've just had, so much fun and learned so much over the years. And, now a lot of my practice is neuroendocrine tumors, small bowel and pancreatic primarily, and their liver metastases. So I've managed many, many hundreds of patients over the years, and I feel blessed to, be able to continue to follow a lot of these people over the years. And I guess that's my story.
Great. He's been an ally of ours for a very long time. Probably you must have presented about at least 20 of our conferences throughout the years. So I'm really excited to get into this. I do want to let everybody know, feel free to ask your questions in the comments. Please don't make them too personal. He's not going to really be able to do anything too granular. It's more of an overview kind of thing. And we have our first question here. First time live, Stacy, patient of yours. Can you talk about the MRN1 test? Is it important to have done, and who should be having it? how do you go about getting it?
Okay, so I'm not sure, Stacy, if you're asking about the MEN1 test. That's
Okay.
because I don't know what the MRN test is, but if you're talking about MEN1,
Might have been a typo.
yeah. And Stacy, feel free to confirm whether that's what you're asking about.
Yes, it is.
Okay, awesome. Okay, because I don't know what that other one is. MEN1 is an inherited cancer syndrome where people can get pancreatic neuroendocrine tumors. They can also get pituitary adenomas. They might make the hormone prolactin up in the pituitary gland. In the pancreas, they might make insulin or gastrin, or maybe not make any hormone. And they also get a disease of the parathyroid glands in the neck, the glands that regulate calcium in your blood. And they can get a variety of other tumors, but those are the three main components. People with pancreatic NETs who have a family history of any of those three conditions may have MEN1. And that is a gene that's inherited through the generations and will put everybody who has an abnormal copy of that gene at risk for developing those tumors. So, Stacy, I can't remember the particulars about your family history or your personal history. Clearly, if you have more than one component, you should have that test done. If you have any family history of any of those components in other family members, you probably should have it be done. But I don't necessarily think that everybody with a pancreatic neuroendocrine tumor has to have that gene testing done. If you wanted to get it done, then the best way to do it is to have your doctor refer you to a genetic counselor. And those genetic counselors will sit down with you and draw a family pedigree and see whether it makes sense that maybe your family is, could have an abnormal copy of that gene. And then after talking to you about the pros and cons of genetic testing, because there could be insurance implications for that. If you have the disease gene, some insurance companies may say you have a pre-existing condition. However, the Genetic Non-Discrimination Act passed by Congress many years ago should make that not happen. But, you never know with insurance companies. But they will talk to you about those issues, and then you can decide whether you want to have the gene test done. And what they would do is just draw a vial of blood, and they would send it to a commercial company that does gene sequencing. And in about a month, you'll have the result back. And if you have a mutation in that gene, that's important to know, because that means that 50 relatives of yours who are first-degree relatives, they'll have a 50-50 chance of also having it, and then they might want to be tested as well. And if you have the mutation, then you need to be screened for these other components. So it's a long answer to your question whether you should have it, but I think I've laid out the background of the people that should definitely have it. And then, some people with just a pancreatic neuroendocrine tumor, sometimes they may want to have it be done just to be sure. But I would say the minority of patients who have pancreatic neuroendocrine tumors would have this condition. It's not that common, but common enough where it makes sense for some people to get it.
Sure. Now, is there any line between or connection between the MEN1 test and something that's come up quite a bit over the past few years in the NET community? And I know there are some really strong opinions on it, the NET test.
Oh, well, the NET test is, that's a completely different thing. I guess before we talk about the NET test, let me just finish with the MEN1 thing.
Sure.
Because if you have MEN1, then your risk of developing multiple tumors in your pancreas over your lifetime is much higher. Whereas most people have one tumor, they will probably only have one tumor. But if MEN1, you may develop tumors over your lifetime. So the strategies for surgery have to take that into account, that you're going to have multiple tumors, and you usually wait till they're over 2 centimeters before you'll go after one. And then you try to deal with the other ones that are present as well as you can. And it's never perfect because there are going to be multiple lesions that might not be removed. But as long as they're small, they probably won't metastasize. All right, NET test. That is an RNA based test that the makers of that test think that it might be more accurate to follow people for recurrence or persistent disease after surgery or after a treatment. And so that draws a tube of blood. They look at RNA sequences or expression values, and it's a proprietary test where they look at, I don't know if it's like 60 genes or something like that, and they come up with a score that might be more sensitive than the typical markers like chromogranin at detecting the fact that you may have recurrent tumor. However, it's a lot of places don't use it. We don't use it, for example. I'm not saying that it's not useful, but I don't know what the cost of the test is, and I would never act on that test alone. I would always need imaging to tell me that you're recurring, that we see new lesions in the liver, for example, before I would change my therapy. So, but that's similar to chromogranin. We wouldn't just give you PRT because your chromogranin went up either. We would use that test in conjunction with some radiology tests that show us that that's what's going on, that you're progressing.
Okay, perfect. We have another one here. To confirm, recommended for a pancreas primary tumor, not necessary if there was a SB primary with spread to the pancreas.
Yeah, that's a good question, Julie, because some people with small bowel neuroendocrine tumors will metastasize not only to the liver, which is a commonplace, but a number of people can have metastases to the pancreas. Now, small bowel neuroendocrine tumor isn't part of the typical constellation of tumors that people with MEN1 get, but some may get small bowel tumors, but it's not your typical thing. So to answer your question, routinely you wouldn't do MEN1 testing if you had a small bowel tumor metastatic to the pancreas, because the people with MEN1 get tumors that start in the pancreas. And a lot of times it's hard to figure out because some people might have both a pancreas and a small bowel, but we published a study that in 11 patients that we examined by sequencing the RNA and looking at immunohistochemistry, that most people who have both tumors in the small bowel and the pancreas of the neuroendocrine type, that in 2/3 they're coming from the small bowel to the pancreas. And in the other third, it might be they actually had a tumor originating in both organs. So it's a little complicated, but if you're small bowel to pancreas, probably not MEN1.
Okay. Do you have any, I know it's still new and I know that there's still a lot of work to be done and stuff like that, but have you been exposed to histotripsy at all? And is that something that University of Iowa is getting into at all, or? Well,
the reps just came by. I watched a demonstration, I think last Tuesday, and I've talked to these guys a lot. The problem that we have is it's a big investment. It's a $1.6 million machine, and you have to get special financing from the hospital. So you have to beg them to buy it. And the company will help you with a business plan to show that it would be worthwhile. But I did watch their demonstration, and basically they took a piece of liver tissue, embedded it in agarose, and then focused the beam on it as a surrogate for doing a liver tissue in a person. And you could see very well how the beam centered on the tissue of interest and how it methodically went around and caused cavitation of this lesion. And then they took the liver tissue out of the agarose and cut it in half, and it all liquefied. So I was impressed with the fact that it could do that. So I think it's an interesting technology. A lot of places have bought it. We haven't yet. There might be interest in our place. Maybe we'll get it. I don't know. But there are some limitations to it. I mean, the great thing about it is that if you have a single lesion or maybe two lesions that are in the right part of the liver, they can treat these without having to cut you open. Which is great because that means your recovery is going to be really, really quick. The downside is that if it's in certain places in the liver, it's sort of hard for them to get to. And also, if it's over a certain size, the histotripsy doesn't work so well. If the tumor is over, say, 3 centimeters or so, it's hard for them to do that. I just saw a patient yesterday who went somewhere to get histotripsy, and I could see the cavity that was created by one of their burns, but I was, well, burn isn't the right word. It's ultrasonication, I guess, is the correct way of saying that. But he apparently had it done 4 times, and I couldn't see the other 3 cavities in the main lesions that I would have thought somebody would have gone after. They didn't. So not really sure what my patient achieved from that. But, the non-invasive nature is very provocative. And I just saw a patient like last week who had 2 relatively small lesions that occurred after he got PRRT, and he's worried because they're getting bigger. And I can do surgery on them at some point, but they're of the size where I wouldn't recommend you have an exploration that requires a 6-week recovery to go after. And I think that's a perfect use of that technology. Most of the patients that I see, for the first time, they have lots of liver lesions, and you can't really do it on lots of liver lesions. You can do it on 1, 2, 3 maybe, but that's about it. So in the population of people I see, those are the people I've already operated on that recurred years and years later, and they might have gotten several treatments, but they only have a few lesions. Those are people I think are great candidates for it.
Great. We have Julie Rankin in the comments here asking, how are your alpha PRRT trials going? And I had a lead PRRT with great results so far.
Oh, she had lead.
Oh, sorry. Lead. Sorry. Yep.
Well, I'm happy to hear that, Julie. I think the trials are going well. At our institution, we have our own lead trial with a different compound called VMT, which is a different company than the Alphamedics that you probably got, that has been given in Houston and Tampa and some other places. And that's just starting, so we don't have a lot of results from that. And then there's the actinium trials that are ongoing as well. So I think they're going very well. I think alpha therapy shows great promise because the energy of the molecules used is stronger than the beta, which is the lutetium-177 that most people get for PRRT. The energy may be stronger. It may not penetrate as far, but it'll do double-stranded DNA damage, which is harder for cells to recover from. So in various presentations I've seen, Dr. Strasberg gave a good one at NANETS just last fall, and their experience, I think it was with about 75 patients. And a lot of the responses look to be maybe a little better than we've seen with lutetium. However, one caveat is, and I don't know if this has been a problem for you, is we don't know what the toxicity to the kidneys is. And, it looks like it's pretty well tolerated and people haven't had a lot of side effects, but we've had some patients who've gotten it, whose creatinine, which is a number we use to follow kidney function, has been going up. And I do have some concerns about whether that could be a side effect of this treatment. So, we're waiting for more results to come out to see if that toxicity is real, or maybe it only happens to a small group of patients.
Great. Where are you at with PRRT in terms of, because I know there's a lot of people going, well, is it the first line of defense? Is it should it be the last line of defense? Where do you kind of lie on it in terms of
with alpha
sequence
or PRRT in general?
In general, the sequencing.
Oh, okay. Well, I think PRRT is a great adjunct. And with the lutetium, we have obviously the most experience because that big trial called NETTER-1 came out in 2018 that led to FDA approval. But as you might know, that's been given in Europe for a couple decades. And like I said, we started our first PRT at Iowa in 2001, but they were clinical trials, so not a lot of patients were getting it. In fact, we even were sending patients to Europe to get it because you didn't have to meet the strict criteria of being enrolled in a trial, which often means that you might not as heavily pretreated, maybe your disease burden isn't as high, you don't have a higher grade tumor, things like that. They don't want you in a clinical trial because they're trying to figure out if the stuff works, and they don't want too many variables that are going to, lead to bad outcomes. They want to have a kind of a earlier population, grade 1 and 2 tumors, and but usually failing other treatments to get there. So getting back to like where I think it should be sequenced, the way we practice at Iowa in general is to do good cytoreduction of the primary tumors and their metastases surgically. And then we'll usually put people on somatostatin analogs. And that will usually work for several years. And then eventually lesions are going to start showing up in the liver again or elsewhere. And when those lesions become larger and are defined or meet the definition of progression, which means a 20% increase in size, of the index lesions, then we would go to PRT. And then, with lutetium, we can count on about 2 or 3 years of good progression-free survival. In other words, it'll often kind of keep the tumors from growing for 2 or 3 years, but eventually they usually start growing again. So it doesn't kill all the tumors. It's not a magic bullet in that way. But it's possible that the alpha therapy could become that. We're certainly hopeful. But we don't know. But that's how we use it. Some people use it differently. Some people will go to it right off the bat. We don't agree with that because PRT does have known toxicity to the bone marrow, and some people will get, after repeated treatments, if you have multiple treatments, your risk of myelodysplastic syndrome, which is a bone marrow problem, or leukemia, goes up. The incidence is only about 2% for people getting PRT for the first time. But if you couple that with like chemotherapy or second round PRT, that number probably goes up. And so we think it's probably safe to get PRT 2 different times perhaps in your lifetime. So we don't like to use it at the very beginning. Sure. We'll save it and then bring it out later because a lot of people can do very well for a long time, and then we use that later when we're kind of running out of those other options when there's progression.
Yeah, you go for the smaller arrows in your quiver there, and then you take out the bazooka.
Yeah,
makes sense. You also brought up exploratory surgery, and that's something that I don't think we talk a whole lot about in general. So could you go about one kind of going into an exploratory surgery? What makes you decide on that particular modality? And number 2, just the process. How does that usually work? I mean, it's obviously different with different situations and different organs, but how often do you go into a situation like that?
Well, when you say exploratory surgery, it makes it sound as if we don't know what we're going to find. And that's kind of what exploratory surgery means to me. But usually when I'm going in, I pretty much know what I'm going to find based on CT scans, MRIs, and PET scans. So, and the decision to do surgery versus some other treatment is whether the patient has a resectable tumor, and that's the primary tumor. And then if they have liver metastases, whether the volume of liver metastases and number are something that's manageable with surgery. And not everybody is. I mean, some people have 100 small metastases in the liver, and that's really hard to take care of with surgery. But, most people who have small bowel neuroendocrine tumors, I will recommend surgery, mostly because a percentage of those patients, a good percentage, will develop a bowel obstruction at some point. And if that happens, they'll end up having surgery in the middle of the night. And a lot of times those surgeries are not great surgeries. They may fix the bowel blockage, but they often won't remove the lymph nodes, and they certainly won't do cytoreduction of liver tumors. So if we can do these operations electively with a plan to take out the primary tumor and then the lymph nodes and then reduce the liver metastases as much as possible, that's the ideal situation. Some people who are extremely frail and don't have a lot of symptoms from a small bowel neuroendocrine tumor, we may elect to observe those people because maybe the risk of surgery is higher than the risk of just watching it. Because there are some people who have very small bowel tumors, even with liver metastases, who, if they don't have symptoms of, say, crampy abdominal pain or recurrent bowel obstruction, they may get along okay with those tumors and still live for many years. So you have to use your judgment about who you operate on. There are some people maybe you shouldn't operate on. But for small bowel tumors, I always worry about the possibility of bowel obstruction. So I will usually recommend to those patients, even if they had disease in their liver that was like so many lesions, I maybe couldn't do cytoreduction, I might still recommend surgery to get rid of the primary tumor that might cause obstruction, or as it grows larger, it may spit cells into the abdominal cavity and cause peritoneal carcinomatosis. For pancreas, it's a little different. Pancreatic surgery has more risks and complications associated with it than small bowel surgery, although you can certainly have complications with small bowel surgery. So it's not, a walk in the park. And those operations generally take incisions that are going to cause pain for about 6 weeks. So there's a recovery period. But for pancreas, location of the tumor is important. If the tumor's in the tail of the gland, it's generally an easier operation than if it's in the head of the gland. The head is the place in the pancreas where the bile duct and the pancreatic duct empty into the duodenum. And when you take out the head of the pancreas, you also have to take out the duodenum and the bile duct. And that leads to the need to reconstruct the bile duct and the pancreatic duct drainage into a loop of intestine and the stomach. So that becomes a more complicated operation that has more complications than, say, a routine resection of the small bowel. So we don't take out every pancreas tumor. We think that in general, when they get over about 2 centimeters, the risk of them metastasizing starts going up, and that's about the threshold where we might decide you should have surgery. If it's like 1 centimeter or was incidentally discovered on a CAT scan, we'll watch those because those have a very low risk of spread. So not everybody needs an operation with a pancreatic tumor. And then, as far as the liver tumor, it really depends on the distribution and the number. But we can often do a pretty good job on people, even who have many, many metastases. I mean, I've taken, tried to cytoreduce patients with 60 or more liver metastases. That's not easy, and you're not going to do as good a job on somebody with that many tumors. But 10 or 20, we can often, do a combination of resection and ablation. But we don't cure people because people with a lot of liver tumors probably have microscopic liver tumors that will show up over time, even if we get all the other ones, which is hard to do the more tumors there are. So generally, to answer your question, Mike, I'll operate on most people's small bowel neuroendocrine tumors to work on the primary and the lymph nodes. And if I can do liver work, I'll do that as well, which we can do in over 2/3 of cases. Pancreas, it depends on the size and the location. I didn't mention function. So if you have a tumor that makes one of those hormones that causes a problem, like insulin or gastrin or VIP or glucagon that cause these hormonal syndromes, then even a 1 centimeter tumor in those people should be taken out. But most tumors, like 79%, don't make a hormone. And when they're under that size, can be watched. And that's generally what we'll do.
Great. Julie DeClerc has a question. My local oncologist switched me from Stanostatin LAR 30 milligrams to lanreotide 60 milligrams with no notice 3 weeks ago. So far, I'm tolerating okay, but do I push back to go back on the Stanostatin?
Well, it's a good question, Julie. I mean, I do think that Sandostatin and lanreotide are essentially equivalent, as far as efficacy. They have different injection modalities, one sub-Q and the other one is IM. The dosage of 60 milligrams of lanreotide is generally about half the dose that most people are on. Most people would be on 120. And that's probably roughly equivalent to about 50 of sandostatin LAR. So you're on a similar dose, I guess, of it being 60 than as you were on the sandostatin. So I don't really have a strong preference one versus the other. I think they're both very effective. So I don't know why your oncologist switched you. Maybe you were having some side effects that he thought it might be worth trying the other one. But I don't think you should be too worried about being on lanreotide instead of sandostatin or vice versa. I think they both can work well. You just have to kind of have an idea of the dosage and whether you're on the right amount. And it's hard to know that. With sandostatin, we usually start at 20, and then we might go to 30, and then you can go to 40 or even 60. It's the maximum dose. And lanreotide, usually it's 90 or 120. So 60 is a little bit on the low side, but if you don't have a lot of disease or if you've had side effects at the higher doses, then that might be a rationale to go to 60. Unless you're getting, I haven't seen too many people on 60 every 2 weeks, unless the dosage interval is decreased. But sometimes people do that, but not very often. Insurance companies don't generally like that.
Yeah, I was going to ask, is there any downside? I mean, aside from somebody who maybe just can't tolerate whatever medication that they get switched on, but something like a changing from sandostatin to lanreotide, is there ever really, or could there be like an interaction or an issue coming off one and going on to another so rapidly, as opposed to kind of winding down one and ramping up the other?
Well, most of the time you probably would wind it down. You would wait the month for the other one to wear off and then start the other one, like when you would have gotten the other shot. So I don't see that as much of a problem. I saw a lady yesterday who was on lanreotide, and she just said that she had these horrible migraines. And I said, well, why don't you get switched to sandostatin and see if you have the migraines, because maybe it'll be better. And, I've also seen people with sandostatin who have problems too. So I'm not advocating one over the other. I think they're both very effective. But, your body may feel better on one versus the other. So I think it's nice to have those two options.
Sure. Clinical trials. Wanted to hop into that subject just a little bit with you. I wanted to see if you guys are involved with any clinical trials, if there's any information you can share about any of them, and what kind of things do you see in the pike for new treatments?
Well, most of the clinical trials we have right now are with these alpha therapy agents, and these again are alpha therapy agents that are made by different companies who are in the business. There are a couple actinium trials, one for people who are PRRT naive, and then there's another one for people who've had PRRT already with lutetium. And then we have this lead VMT trial, and I don't remember all the eligibility criteria. And then we're involved with the Alliance Oncology group, and the neuroendocrine group in Alliance has several trials open. One of the ones that was recently completed was the cabozantinib trial, and that showed a benefit, and that was really awesome. And Jennifer Chan led that trial, and the results were published last year, and it's now approved for both SB-NETs and PNETs. And it is just another thing that we can use for small bowel neuroendocrine tumors. With pancreas, there are several therapies that are useful, but with small bowel, there have been less options. So it was really good to have a new one, although the drug has some toxicity. There are a few other trials in the Alliance, and I'm not sure how many of those we have open. There are like at least 2 or 3 that are ongoing. There's the PRT for pulmonary carcinoids versus everolimus, I believe. And then there's another trial with PNETs that's looking at, I can't remember if it's CAP10 versus PRT, but there are about 3 alliance trials. I'm not sure which ones we have open at our institution, but I'm in the alliance group, and I do hear about these things. And a lot of them are slow to accrue, and they can take several years to get enough patients and then for follow-up to see if there's a difference. So in a lot of these trials, we may not know for a few years. As far as other things coming down the pipe, I think the alpha therapy is the most exciting right now. As far as new drugs, I've heard of some new drug conjugates which are targeting the somatostatin receptors but may have chemotherapy attached to them. So those are kind of interesting, but they're very much boutique trials. And then I heard that Jennifer Eads at University of Pennsylvania is starting a CAR-T trial, which is a type of therapy which has been very effective in liquid tumors like leukemias and lymphomas and things like that, but not as effective in solid tumors like neuroendocrine. So it sounds like they're starting a trial there, which will be very exciting too. And maybe something people might be interested in.
That's great. Now, for the people that are, we've covered this several times, and I like to have this discussion a little bit, only because I think people, they get worried about the, I'm going to go into a clinical trial and I'm going to get a placebo and all that stuff. We've probably on this live stream and in the podcast have ad nauseum kind of talked about the placebo thing not happening, not really happening. But as far as the other things that you have to be concerned with in terms of being involved in a clinical trial, such as travel and meal expenses, etc. If you're traveling out of state, does the University of Iowa have any resources or things in place to help people along with those situations?
Well, not resources in terms of paying for their travel and so forth. The only place I know that can do that is the NIH, and even that is in question now. They've had to shut down some of their trials because of recent changes in government and lack of funding at the NIH, and then people leaving the NIH because they were deemed unnecessary by DOJ. So a lot of those trials that used to get paid for at the NIH I think have been stalled, and they've not been accruing, or that maybe they're waiting to see how things are going to work out. We have a Hope Lodge where people can potentially stay if they're on a clinical trial, but not, and it may be that the drug may be paid for by the company, but a lot of the stuff like imaging, which would be standard of care already, would probably be billed to insurance. So the University of Iowa doesn't have a lot of resources to pay for patients on a clinical trial.
Well, I meant a little bit more like rather not just actual money. I just meant like somebody that can kind of help somebody in a clinical trial navigate it, like say a social worker or somebody.
Yeah, nurse coordinators. I mean, the clinical trials always have nurse coordinators assigned with them, and they're very good at helping people facilitate through that process. Whether it be a place to stay or what to expect, at least, you're going to be here for 1 day or 2 days, or, how long is it going to take? So, yeah, most places that will have clinical trials will have very, very skilled people, because it requires that kind of infrastructure to even carry one out. Sure. And so they have really good nurse coordinators pretty much everywhere they do clinical trials. You were talking, Mike, about placebo not being a thing, and maybe what you're referring to is that in a lot of neuroendocrine trials, if you're on the placebo arm, you're allowed to cross over to the treatment arm. Maybe that's what you're.
Yeah, well, I shouldn't have said it that way. What I should have said was they're not going to leave you without any sort of treatment at all. I think that people are worried about, okay, well, if I go on this clinical trial, I'm already on a medicine that works. I'm going to get off this medicine that works and take this placebo pill, and then I'm going to get sick and die and all that.
Yeah.
Yeah.
There are a lot of the things that I talked about. There is no placebo arm to it. But like the early studies with sandostatin and lanreotide had a placebo arm. And the thing about it is the people who were later shown that they were on placebo, if they had progression, they could cross over to the PRT arm. And that's good for the patients because, if you didn't get the treatment and you progressed, then you could still get the treatment. But the thing it's bad for, and again, this is a problem with neuroendocrine tumors, is that the endpoint of overall survival of treatment A versus treatment B is hard to assess if everybody crosses over to the treatment arm. So if you really want to know if, say, for example, sandostatin patients versus placebo live longer, if you allow for crossover, you can really only use an endpoint of progression-free survival, which means how long did it take you to progress or develop more tumors or bigger tumors, rather than overall survival. And a lot of those trials have shown no difference in overall survival, but mostly because there's so much crossover. And so it makes it really hard to know, if those things should be used long-term, because maybe it does or maybe it doesn't benefit overall survival. So it's confusing to have crossover, but it's actually good for patients too, because they don't end up with no treatment.
Right. You're not getting that, well, this progresses so far in this amount of time, and then they cross over to the actual PRRT arm, and then they're no longer, it's not progressing anymore, obviously. So
it's complicated, and that's why clinical trials are so important. And with neuroendocrine tumors, the other challenge is that people generally live a long time. If you look at, say, pancreatic adenocarcinoma, where a lot of people will die within 1 to 3 years, you can look at overall survival of treatment A versus treatment B, because patients don't live for 10 or 15 years because you run out of money following people on your clinical trial. So it's hard to do some of those trials in neuroendocrine, which is a good thing, I guess, because people live a long time.
Yeah. And one last thing I do want to ask about is, mental health in the neuroendocrine world. In your facility, in your institution, obviously as a surgeon, a lot of these surgeries are major surgeries and require a lot of work going into it and a lot of work coming back once you're out of it. It could be a traumatic experience. So at the University of Iowa, do you tend to point people toward any kind of mental health and help or social workers or anything like that? Is there something in the multidisciplinary sphere of the University of Iowa for that patients?
When people come into the clinic, they fill out these questionnaires with distress scores and things like that. And if they're above a certain level, then I'll be notified about that and I'll keep that in mind. But there is a lot, of stress going through a major operation. And, I try to relieve that as much as I can by just talking to people. If people really have a mental health issue, then, or serious depression over this thing, then we have psychiatry nurses who are often the first line of people that will talk to these individuals. And oftentimes people just need somebody to listen to them, and just to talk things through. And that can be very effective, just to have those conversations. But if people really need more in-depth psychiatric help, then we can get the psychiatrists involved. But in the clinic, that's not a huge part of our multidisciplinary care. We're really more focused on, surgery, endocrinology, medical oncology, nuclear medicine. And if people, show high distress scores or have an interest in that, we do definitely have people we can hook them up with. But I wouldn't say it's routine that we would, have them go talk to a psychiatrist or a support person. A lot of that is our job as physicians to try to make people feel more comfortable with where they're at, educate them, and then having the NCAN community and other neuroendocrine communities is a huge thing for people to just be able to talk to other people with this rare tumor that, they may not have seen in their local area. Actually just being in the waiting room, people seem to meet other people with the same problem. And that can be so reassuring to people that, hey, I'm not alone. And then, to get on with NCAN and see that there's this whole wonderful community of people that will help each other out is often enough for most people to really help them get through this.
Yeah, absolutely. Great. Well, Dr. Howe, thank you so much for your time. Appreciate it. It's not easy getting you on a weeknight during the week, you and any of the other doctors. So we really do appreciate your time and your expertise that you're sharing with us. I want to thank everybody that is watching or has watched or has, this video is going to be out now forever. So hopefully anybody who's watching, you got something out of this. Please remember that if we're in your area, come to a net patient conference that by NCAN. We're going to be in Minneapolis, June 21st with Dr. Howe. We're going to be in Birmingham, Alabama, July 19th. We're going to be in New Jersey. We're going to be in Miami. And you can get all that information over at netcancerawareness.org. Don't forget to follow us on social media at netcanceraware. That's on all the socials across the board. And we'll see you in a couple of months for the next Q&A. Thank you, everybody.
Bye-bye.